ඔව් සර් එනවා. ස්ක්‍රීන් එකත් පේනවා.
Okay. පටන් ගමුද අපි එහෙනම්?
පටන් ගමු.
Right. Okay. So yesterday we stopped here. Today, so again, so what we'll do, we try to do as much as possible. මේ අදාර busy දවසක් නිසා මම කොහොම හරි ඔයගොල්ලෝ කරන්න ඕන කමට තමයි මේ දාගත්තේ නැත්නම් වෙලා මදි වෙනවා. Right. So this question focuses on thyroid function tests. Sorry. Now, thyroid function tests can be tricky sometimes, but if you first focus on the straightforward things, right? In a patient with primary hypothyroidism, right, where there's a disorder in the gland, they will have low T3, T4 and a high TSH, right? So that is in primary hypothyroidism. Very straightforward. The patient will have clinical features of hypothyroidism, a high TSH and a low T3, T4, right? Then on the other hand, sometimes you get patients with in primary hyperthyroidism where the TSH is low and the free T3, T4 is high. So this is a simple, those are the simple disorders, but can be occasionally tricky, and this MCQ focuses on some of the tricky ones as well. Right, so let's go. Free T4 is the investigation of choice in suspected primary hypothyroidism. So as we discussed yesterday, the TSH is much more reflective of the diagnosis in primary hypothyroidism. Of course, you do both together, but the TSH is a reflection of whether of the diagnosis as well as adequate thyroid hormone replacement in hypothyroidism, right? As we discussed yesterday, the free T4 is a sort of changes more acutely, but the TSH gives a better idea of the long-term control in a patient on thyroxine as well, right? So that is not the investigation of choice. TSH would be the correct answer there. Now, occasionally we have patients who have a low TSH and a low T3, T4. Now, how would we interpret that? So you have a patient with low TSH and low T3, T4. Right? That is sometimes you see this pattern, right? If this occurs in the setting of hypothyroidism, where the patient is clinically hypothyroid, right? This patient is clinically hypothyroid and has low TSH and low T3, T4, this indicates a pituitary problem or secondary hypothyroidism, where the pituitary axis is failing or the hypothalamic axis is failing, and that's giving rise to low T3, T4. So you see this pattern very commonly in patients with pituitary problems, pituitary tumors, hypopituitarism. Right. You might also see this picture where the patient is clinically euthyroid. Nothing else, patient clinically euthyroid, but low TSH and low T3, T4. Right? Patient is clinically euthyroid. Right? This is associated with something called sick euthyroid syndrome. And we sometimes see this in acute illness when they have an infection or something, right, or some inflammatory process going on. There is a suppression of the pituitary thyroid axis, and that is called sick euthyroid syndrome. So these patients will be low TSH, but low T3, T4, but they are clinically euthyroid, right? So that is right. So sick euthyroid therapy. And this occurs in intercurrent illness, inflammation, states වලදී තමයි එන්නේ. Right. So in pituitary disease, I specifically told you that TSH එක අඩු වෙනවා and the T3, T4 will be lower. Right. Okay. Very rarely, you can get TSH secreting pituitary tumors or TRH secreting hypothalamic tumors that can cause hyperthyroidism, but that's very rare. Right. Okay, so we talked about the common things, and another thing you need to know is the TSH, low T3, T4 scenario. If they are hypothyroid, that indicates a pituitary issue. If they are euthyroid, that will probably indicate sick euthyroid syndrome. Hari. Okay. Now මෙතන MCQ එකක් අහලා නැහැ. තව tricky එකක් තියෙනවා මෙන්න මෙහෙම. Patient is hyperthyroid, right? Patient is hyperthyroid clinically, right? The TSH is low, right, or suppressed, which you expect to see, right? But the T4 is normal, right? So that is a okay, very tricky MCQ එකක් ඕක. මම හිතන්නේ best response එක තිබුණාද මම මතක නැහැ. So essentially we'll have a clinically hyperthyroid patient, right, with low TSH but normal T4, normal T4, right? What is that? කවුරු කියන්න බෑ?
Poor compliance.
Poor compliance. Poor compliance වලට එහෙම එකක් එන්නේ නෑනේ. Patient hyperthyroid කියලා clinically තියෙනවා, right? So clinically hyperthyroid. So that's yes.
T3 toxicity.
Yes, Harishankar is right, and so it's about T3 toxicosis. ඒතර හංගල දෙන්නේ T3 එක කියන්නේ නැතුව දෙනවා T4 එක normal කියලා, right? So that is T3 toxicosis, right? Another one is when මෙහෙම එකක්. Patient is clinically hyperthyroid, right? T4 is high, but T3 is low or normal. සාමාන්‍යයෙන් දන්නවා thyrotoxicosis වලදී you have to get a T4 and that causes a concomitant rise in the T3 නේ. TSH එක අඩු වෙලා T4 T3 වැඩි වෙනවා. That is what we usually know. But this scenario, patient is clinically hyperthyroid, TSH is suppressed as you would expect it to be, T4 is high, but T3 is normal. What is that? Go. කවුරු කියන්නේ? So hyperthyroid, TSH is suppressed, T4 is high, T3 is normal.
Poor compliance to antithyroid medication.
Poor compliance to antithyroid medication. Still the T3 might be a bit high in that situation also, right? Okay, so Harishankar, that's possible. There are rare syndromes where the T4 to T3 conversion enzymes are deficient, so that is a possibility. But commonly people take overdose of thyroxine, right? සමහර වෙලාවට in the acute stages of acute overdose of thyroxine, this can happen, right? The T4 will be high, T3 එක හැදෙන්න කල් යනවා, right? So T3 is normal or suppressed immediately after they take a massive overdose of thyroxine in the acute stages, and the TSH can be suppressed. So these are some tricky things that you can occasionally come across in MCQs, right? What happens to the T4 in pregnancy? As you know, in pregnancy, the plasma protein content increases. So what really happens is the total T4 is increased, right? Because the loss of thyroxine bound to albumin when the plasma protein increases, right? But the circulating TSH or the free T4 is what you need to measure, right? So the total T4 is falsely elevated in pregnancy. So we always measure the free T4, right? මේ අන්තිම MCQ එක කපා ගන්න එක වැඩක් නැහැ. හරි? That's a postgraduate thing. මම මොන මවනවා හිතලා දැම්මත් දන්නේ. හරි.
Sir, would you mind repeating what you just said? That last.
Yeah, so in pregnancy what happens is there is increased plasma protein content and a compensated rise in the T4 bound to the plasma proteins, but it is no action. Hurry. So the total T4 content is high, but the actual circulating free T4 content is normal, hurry, in pregnancy. So that is always where you measure the circulating free T4 content in pregnancy. There's no point in measuring the total T4 because it will be high, right?
Yes, sir. So, sir, is it a false increase?
Falsely high anyway. Yes, it's high. Sorry. That word is wrong. It has to be high. Yeah. Falsely high anyway. Right.
Sir, the fourth statement, is it true?
That's false. Ne? TSH Arduino cure? Yeah, sorry. Okay. Right. So from question 15 onwards, we move on to adrenal problems, right? And the first thing we are going to talk about is primary hypoadrenalism. Again, one of these MCQs that what are the causes of primary hypoaldosteronism or okkoma hari, right? Okkoma hari, this primary hypoaldosteronism secondary to pneumococcal infection is also called Waterhouse-Friderichsen syndrome. Right? They get sort of adrenal infarcts in pneumococcal infection, bilateral adrenal infarcts. That's called Waterhouse-Friderichsen syndrome. syndrome. හරි ඒක MCQ වල ওই නමින්ම දෙන්නත් පුළුවන්.
Excuse me sir, ඕක meningococcal වලත් එනවා දෙකෙන්
meningococcal වලත් එනවා. Yes, meningococcal වලත් එනවා. They get bilateral adrenal infarcts. Nipun has asked a very good question. අපි free T4 නේද සාමාන්‍යමයි? Yes, but it's a bit more expensive to do the free T4. Yes, සමහරලාට අපි total T4 කරන වෙලාවලුත් තියෙනවා non-pregnant patient. That will give you the same information because measuring free T4 can be a little bit more expensive than total T4 because the test is slightly different. Right? But if you are measuring free T4, no problem, whatever it is. But of course, if you are in a resource limited setting, you could measure the total T4 in a non-pregnant patient. Right? Right. Okay. Right. Now, Addison's disease is an adrenal dysfunction secondary to a sort of immunological process, right? Sort of autoimmune process involving the adrenal gland. Right? And like all other autoimmune diseases, right, Addison's disease is associated with other autoimmune diseases like pernicious anemia, which is a common association. Also, things like Hashimoto's thyroiditis can be associated with Addison's disease, right? Because it's a same sort of autoimmune spectrum disorder. Autoimmune spectrum disorder, right? And also like pernicious anemia, they can get autoimmune ovarian failure as well, right? So autoimmune ovarian failure, autoimmune pernicious anemia, autoimmune thyroiditis, all these things can coexist with Addison's disease. Now, the typical clinical presentation of Addison's is with hyperpigmentation, right? So you know that they will have hyperpigmentation. And because, of course, we are pigmented generally as a population, looking for pigmentation in the buccal mucosa and the tongue is especially important in a Asian population like a Sri Lankan population. So pigmentation is a very important feature. Of course, they will have other symptoms like they will feel tired all the time, right? They will have postural dizziness. And if you measure their postural blood pressure, they will have postural hypotension, right? That is very common, right? But they will generally feel aches and pains, anorexia, malaise, right? Weak all the time. Those are the common presentations. So postural hypotension is a feature, is true, right? Is a feature, is true, right? Okay. Right. Now, once you have this clinical syndrome, right? Suggestive clinical syndrome. By the way, this is a sort of on X-ray, you might see adrenal calcifications in a patient with Addison's disease. Adrenal calcifications also seen in people with post-TB hypoadrenalism. That's the well-known complication of tuberculosis, post-TB hypoadrenalism. So you get calcifications. You know, Addison's, you will get calcifications. Right. Now, how do we diagnose Addison's? You suspect it with the clinical syndrome, with the pigmentation, with the postural hypotension, right? But because of the cortisol deficiency, they get hyponatremia and hypokalemia, right? And also hypoglycemia, right? That is very important. There are certain other slightly unusual things also which are associated, like a slight hypercalcemia, right? Slight hypercalcemia. And also an eosinophilia, right? These are also associated, and okay, occasionally we ask these in MCQ. Don't ask me why, but these are associations, right, with Addison's disease, right? So these are the sort of common things that you see, right? Now, in order to confirm a diagnosis of Addison's, we can use the random cortisol as a guide, right? Now, the random cortisol, you might ask me, okay, can you use that as a diagnostic tool? The random cortisol can be used in a specific situation, right? For example, if your random cortisol, right, is more than 500, right? Random cortisol is more than 500 nanomoles per liter, you can confidently exclude Addison's disease, right? And that is based on lots of evidence and sort of studies, biochemical studies over a large period of time. So currently we know if the random cortisol is or even the random or even the random cortisol is useful, If the random cortisol is more than 500, at any time you can exclude adrenal insufficiency. Right. If it's less than 100 nanomoles per liter, adrenal insufficiency highly likely, right? But currently, based on recommendation, I'll tell you why in a minute. If your random cortisol is between 100 to 500, we recommend that you do a stimulatory challenge, and this is with the short synapton test. දැන් මේක මෙහෙම specifically කියන්න හේතුවක් තියෙනවා. The short synapton test, the reagent is very difficult to get, right? ඒක දැන් produce කරන්නේ නැහැ. It is very difficult to get hold of. So people have come up with alternate ways of diagnosing Addison's disease. So currently we say if it's more than 500, you can exclude it. If it's less than 100, you can diagnose it, right? If it's 100 to 500, you need additional quantification by stressing out the adrenal or stimulating the adrenal to see if it produces any cortisol, and that is with the short synapton test. So MCQ එක ගහනකොට පොඩ්ඩක් පරිස්සම් වෙන්න ඕනේ. Diagnosis is excluded if the random cortisol is normal කියන්න බෑ. හරිද? Because even between 100 to 500, that is still normal, right? 100 to 500, that is still normal, right? So you can't say that a normal random cortisol excludes the diagnosis. You have to be very specifically, you have to specifically mention the exact value, right? So it's more than 500, yes, right? You can exclude it. The parissameng yanna one. And adrenal calcifications may be seen on X-ray abdomen is true. That's what I just showed you. In Addison's disease, you would get adrenal calcifications. Also, we see adrenal calcifications in post-tuberculous adrenal insufficiency. Right. Okay. Any questions about that one?
So is this screening test this random cortisol or what this 9 AM?
Oh, මෙමයි. ඒක 9 AM වලට කරාට ඕක random කරාට ප්‍රශ්නයක් නැහැ. Right? So people are very focused on doing this random at 9, but එහෙම ලොකු ප්‍රශ්නයක් නැහැ. You can do it at any time, and you can use this as a guide, right? This 100 to 500 ඒක 9 AM වෙන්න ඕනේ කියලා එකක් නැහැ. සාමාන්‍ය ඒ වෙලාවට තමයි කරන්නේ for uniformity, but it doesn't always have to be done at 9 o'clock. Hari, even a random cortisol can be useful. Yeah.
Right. Thank you.
So a screening test කියන එකත් තිසුණා දැන් ඔය අපි කියන්නේ නැහැ. You can use as even as a definitive test the random cortisol or 9 AM or whatever you call it can be used. Right? As long as it's more than 500, you can actually exclude it. Right? So screening mat නෙවෙයි, sometimes it is diagnostic also. This is because of the lack of the SST reagents that people are coming up with various other ways of diagnosing. Right. Of course, as you know, management is with cortisol replacement, and the drug of choice is hydrocortisone. Right. Now, most of the time, replacing hydrocortisone is adequate to establish clinical improvement. But occasionally, a small subset of patients still have postural hypotension despite being on a good dose of hydrocortisone. Right. In those patients, we additionally put them on fludrocortisone as well. Right. So hamartomer fludrocortisone, we don't need to give fludrocortisone to everybody. It's only in the patients who persist to have postural hypotension despite being on a good hydrocortisone dose. Right. And usually the hydrocortisone dose is split up, where 2/3 are given in the morning and 1/3 in the afternoon. Right. This also reflects the diurnal variation of cortisol secretion, where we need more cortisol in the active times of the day in the morning. Right. That is why we give most dose in the morning. Right. So this is about adrenal insufficiency. Right. So let's move on then to Cushing syndrome, which is hyperadrenalism or secretion of cortisol, corticosteroids. Right. And all of you should be able to identify in a picture the manifestation of Cushing's, the phenotype of Cushing's, right? The typical moon-shaped face, as you can see the picture on your left side, right? And then the wide purplish stripe in the abdomen, right? Now, diagnosis of Cushing syndrome is a slightly complicated process, right? But we generally use a flow chart or a flow algorithm to diagnose Cushing syndrome and to determine the cause. Now, broadly, Cushing syndrome can be due to ACTH dependent causes or ACTH independent causes. Examples of ACTH independent causes are common things like steroid overdose or prolonged use of steroids, right? These are ACTH independent causes of Cushing's, right? And then you have ACTH independent dependent causes, either due to a pituitary tumor that secretes ACTH, or say, for example, ectopic ACTH secreting tumor in the lung, for example, right? So these are ACTH dependent causes. ACTH dependent causes, right? Right. So Cushing syndrome is most commonly due to pituitary disease. If you take Cushing syndrome, it is most often due to ACTH independent due to steroid. Okay, it's iatrogenic or ACTH independent Cushing's due to steroids is the most common cause, right, worldwide. Right. Okay. So this is the classification: ACTH dependent, ACTH independent. So within the ACTH dependent group, you have pituitary tumor-related ACTH or ectopic ACTH. Cushing's disease කියලා කියන්නේ, specifically this word Cushing's disease, people traditionally refer to a pituitary microadenoma related Cushing's. Cushing's disease කියන term එක classically is described for a pituitary microadenoma secreting ACTH and causing Cushing's. Right. Now, apart from the classical features that you have just seen, like the moon phase, right, like the purple, pink, purple, white striae, there are other features of Cushing syndrome, right? Particularly, I'd like to bring your attention to the neurological manifestations, right? When they have high cortisol, they get irritable, they have sort of psychosis sometimes, right? And they have proximal myopathy, which is an important feature, right? As you know, high steroid levels can cause osteoporosis and pathological fractures as well, right? And of course, high steroids can cause hypertension, diabetes, as endocrine complications. So proximal myopathy is a presenting feature. Hirsutism is also a feature. So within the skin-related manifestations, we have already seen the white purplish striae, but remember it also causes acne, coarsened facial features, hirsutism as well. Right. So these are common features of Cushing's. Right. Okay. Right. Now let's move on to how you would diagnose Cushing's and try to reach a cause. So how to make a determination of what the cause of the Cushing's is. Now, the first thing you do for Cushing's is we use screening tests, right? So there are certain screening tests that we use. Now, in the literature, people use several screening tests, right? For example, one of the things we use are the 24-hour urinary free cortisol test. Right? So that is something that you can do as a screening test, 24-hour urinary free cortisol, right? Also another, but remember you have to collect the urine for 24 hours in that test. A spot test might be a midnight salivary cortisol. Again, this is a timed midnight salivary or plasma cortisol. Okay, plasma already salivary tama godak වෙලාවට කරන්නේ, right? Salivary cortisol. Another screening test that we commonly use in Sri Lanka is the overnight dexamethasone suppression test. Overnight dexamethasone suppression test, very easy to do. Give 1 milligrams of dexamethasone overnight and then measure the cortisol at 8, right? And there is a cutoff value. But generally, the thing I have to say here is, unlike for Addison's disease, random measurements of cortisol have no place in either screening or confirmation of Cushing's. There has to be one of these sort of very specific criteria. Either you measure it in the urine for 24 hours, a midnight salivary cortisol, or you do a overnight dexamethasone suppression test and measure the cortisol in the morning. So these are the things that you do as screening for Cushing's, right? Now, once you screen the patient for Cushing's, then you have to confirm the Cushing's. And for that, use another variation of a dexamethasone suppression test, which is the low-dose dexamethasone suppression test, where you give 0.5 milligrams of dex for 6 hourly for 2 days, right? For 2 days. And then you measure their cortisol. With this, you can also do something called a CRH stimulation test. And that is sometimes important in something called pseudo-Cushing. So people who take alcohol can develop a Cushing's phenotype, right? And they develop something called pseudo-Cushing's, right? Alcohol ganna එක තමයි ගොඩක් වෙලාවට අපි ඔක දකින්නේ. Right? So they are unresponsive to this CRH stimulation test. That is a MCQ point අහන එකක් නෑ ඔයගොල්ලෝගේ, but නිකන් මතක තියාගන්න. So once you go through your screening processes, 24 unit cortisol, dexamethasone separate, overnight dexamethasone or a midnight salivary cortisol, now you move on to confirmation with a low dose dexamethasone. And if they cannot suppress their steroids with a low dose dexamethasone suppression test, you will diagnose Cushing's syndrome. Right. So let's go back to that MCQ. Random serum cortisol, again I emphasize that it has no use in diagnosing Cushing's syndrome. Right? Even though it has a utility in Addison's, it doesn't have, or adrenal insufficiency, it doesn't have a place in Cushing's. Right. Okay. Any questions up to now? So, බාට් ඔයගොල්ලෝ දැකලා තියෙනවද දන්නේ ලංකාවේ ගොඩක් වෙලාවට අපි කරන්නේ මේ overnight DEXA එක තමයි ගොඩාක් වෙලාවට for screening.
Sir, මේ screening test දෙකක් positive නම්
Yes.
you
Yes.
can confirm Cushing's එහෙම එකක් තියෙනවා?
එහෙම confirm කරන්න බෑ. But of course, the more the screening tests positive, the more likely the diagnosis is correct, right? Actually, some guidelines advocate that you have to have 2 out of 3 or something positive to proceed in this algorithm. හරි? So ඒවා කොහොම ලංකාවේ තුනම කරන්නේ නැහැ. ඒ නිසා අපි ගොඩක් වෙලාට එකකින් වගේ තමයි ගිහලා then we do the low dose dexamethasone ඊට පස්සේ. හරි?
Right, sir. Thank you.
හරි? Right. Now, then what you need to do is, now you need to figure out, is your Cushing syndrome ACTH dependent or ACTH independent, right? So for this, you need to measure the ACTH level, right? And figure out whether it is driven by ACTH or if the ACTH is suppressed. And that indicates ACTH independent cause, right? ACTH dependent Cushing's can be pituitary or ectopic, right? Now, මෙන්න මේක පොඩ්ඩක් බලන්න. There are certain special features about ectopic ACTH producing tumors that you need to know about. Very special දේවල් ටිකක් තියෙනවා. හරි, we'll come to Hasni, I'll come to your question. Give me a second. හරි, special features ටිකක් තියෙනවා. Right. Now, what are these special features? One thing is that ectopic ACTH secreting tumors are very rapidly growing, right? And if you don't do something about them, the patient will die very fast. So what you see are, they don't have the full-blown Cushing story. So you don't see the classical Cushing's phenotype in these patients. But what you see, and actually weight loss is a more prominent feature because of the malignancy, right? So they see weight loss rather than the classical Cushing's phenotype. But what they do have is very significant hyperpigmentation because, as you know, ACTH causes melanocyte stimulation to produce melanin, and they get very severe hyperpigmentation, right? And also they have a very prominent metabolic profile where they have a lot marked hypokalemia, right? And metabolic alkalosis, right? Metabolic alkalosis. So that's a special thing. Now going back to our algorithm, and I think partly we'll answer Hasini's question as well, right? Now, how do we differentiate pituitary from ectopic? So both are ACTH dependent. Ectopic has certain classical features, like they have lots of hyperpigmentation, they don't have the classical phenotype, and they have marked hypokalemia. Apart from that, a general principle is, in pituitary tumors, even though they have Cushing's, they still can demonstrate a little bit of regulation of their axis, of their CRH, ACTH, cortisol axis. So pituitary thama regulation is slightly intact. But in ectopic, there is no regulation. Right? There is no regulation at all in that axis. So, if we give patients high dose dexamethasone, right? high dose dexamethasone, most pituitary tumors will suppress with that, right? Because there's a little bit of regulation that is still intact. So if you give them high dose dexamethasone, they can still regulate their cortisol. So they will suppress with a high dose. Also, because the regulation is intact, if we give them CRH, you will see an increase in cortisol in the pituitary. Because it's still under regulation. දෙපැත්තම බලන්න පුළුවන්. High dose දුන්නම suppress වෙනවා, CRH දුන්නම stimulate වෙනවා. So still there is a little bit of a regulation within that axis in pituitary. But in ectopic ACTH, they don't respond to high dose dexamethasone and they don't respond to CRH stimulation. That's what Hasni was asking. So ectopic ACTH, they don't respond to CRH stimulation because there is no regulation within that axis. So, so when you have confirmed Cushing syndrome using the ACTH, you say, okay, is ACTH dependent or ACTH independent. ACTH dependent could be pituitary ectopic, and ectopic has certain characteristic features and also do not respond to CRH stimulation and do not suppress even with the high dose dexamethasone suppression test. That is how you diagnose an ectopic ACTH. And once you have done all these tests, all these endocrine tests, you do imaging to confirm. Right? You do imaging to confirm. Right? Nikang ohe imaging karanna. You have to have this endocrine validation before you proceed to image. Right. Okay. So pituitary tumors you will see in a MRI, and remember some people with pituitary tumors might even have a normal MRI. එතකොට අපි අර කරනවා venous sinus sampling කියලා very special test එකක් to check what side of the pituitary there is more cortisol coming from, right? That is a very more cortisol, more ACTH coming from, right? That is a very advanced test called venous sinus sampling. Right. Okay. So now this MCQ question number 18 is based on what we have learned about ectopic ACTH secreting. Ectopics are not pseudo-Cushings, Asni. They are not pseudo-Cushings. They are true Cushings, right? Pseudo-Cushings is alcohol. ඒවත් ACT CRH respond කරන්නේ මොකද කිසිම ACTH කතන්දරයක් නැහැ නේද? හරි? That is a completely different mechanism. හරි?
Sir?
Oh.
Sir, so pseudo-Cushing, they just don't have the Cushingite features and hyperpigmentation.
Yeah, there is no activity in the ACTH CRH axis. No. Yeah.
Oh.
Okay. So regarding ectopic ACTH producing tumors, Cushingite features are apparent in the majority කෙනෙක් බැරදි මම එක කිව්වා because these tumors are rapidly growing. They don't have time to manifest the Cushing's phenotype. So what they have is hyperpigmentation, and that is severe hyperpigmentation. Hypokalemic alkalosis is a common finding. ඒක හරි නේද? Because of the, I told you they have very prominent metabolic hypokalemia and alkalosis. Cortisol levels are readily suppressed by low dose බොරු කතාද low dose තියා high dose එකෙන්වත් suppress වෙන්නේ නැහැ. And CRH test එකට exaggerated ACTH cortisol response එකක් එන්නේ නැහැ. That's wrong. Right? All things we have learned now. Right. Now, a word about the other side of the axis, which is the ACTH independent axis. As I told you, the commonest cause of all Cushing syndrome, and obviously ACTH independent Cushing's, is iatrogenic, like steroid induced. But of course, rarely you can get adrenal adenomas that secrete corticosteroids, right? Or adrenal carcinomas that secrete corticosteroids, right? And there are certain tests like this 17-keto steroid DHEA in the blood and urine that are elevated in adrenal carcinomas. Right. So Cushing syndrome, pituitary MRI demonstrates a lesion in more than 90% of the cases කියන එක වැරදි, right? In about 20% it is normal. Virilization is noted in patients with adrenal carcinoma. That is true because these adrenal tumors can produce sex hormones as well, as you know, right? And that can cause virilization. Increase of 17 keto steroids in urine is indicative of adrenal adenoma, and adrenal carcinoma. Right? Right. Now, how do you treat Cushing syndrome? Right? Cushing syndrome has an extremely poor prognosis. If you don't treat Cushing syndrome in time, they will have lots of complications and die. So surgery is the preferred option. For whatever Cushing, surgery is the preferred option. But occasionally until surgery to sort of get some medical effects, we use these two drugs which block the synthesis of cortisol, metilopone or ketoconazole in the short term until we can offer the patient surgery. Right? But surgery is the preferred option in the management. Right? Surgery is the preferred option. Right. So make a hurry. Yeah. Right. Any questions? Oh, sorry.
Sir, in the previous question, like two questions back, what is the role of this long synectant?
Long synectant එක දැන් පාවිච්චි කරන්නේ. Right? So yeah, that is not used now. Don't worry about it. හරිනේ. Right. So we talked about investigations. කවුරු 9am cortisol කියන්නේ උදේ 9ට cortisol එක බලන එක මම කිව්වා ඒක එච්චරම ලොකු වැදගත්කමක් නැහැ. In addition, you can even random cortisol at any time can give you a good idea about what's going on. හරිද? මොකද patient කෙනෙක් ආව emergency department එකට මේ suspected Addison එක උදේ 9 වෙනකන් ඉන්න බෑනේ blood එකක් කරන්න. And you can't wait because remember when you give hydrocortisone as empirical therapy it affects some of these tests. බලබලින්න බෑනේ ටක් ගාලා බ්ලඩ් එකක් අරගෙන යවලා අපි බලනවා cortisol එක random cortisol එක කීයද කියලා, right? So yes. Okay, before we go to this මම මේක අන්තිම දවසේ කරන්නම් because මෙතන can we go මේ සමත් අර අලුත් part 2 එක හම්බුණා නේද ඔයගොල්ලන්ට?
ඔව් සර් part 2 එක හම්බුණා.
ඒක පොඩ්ඩක්
අනේ PowerPoint එක හම්බුනේ නැහැ සර්. PowerPoint එක හම්බුනේ නැහැ, question paper එක විතරයි මම හිතන්නේ හම්බුනේ.
පොඩ්ඩක් මම දැම්ම බලන්නකෝ ඒක ඇවිල්ලා
PowerPoint එක තියෙනවා
නේද? ඒක පස්සේ මේ දැම්මේ ටිකකට කලින් දැම්මේ ඒක sorry. මේ ඒකේ අපි ප්‍රශ්න ටිකක් තියෙනවා ඒක ඉස්සෙල්ලා ඉවර කරලා ඉමු. Still about adrenal. හරිද? ඒක ඉවර කරලා අපි යමු මෙතන. So ඒක මැදේ ප්‍රශ්න 1 2 and 1 and 2 are all still adrenal. So let's finish that off before we go to the best response. ගායනි මට තේරෙනවා මොකක්ද කියන්නේ pituitary adenoma and Cushing syndrome කියන්නේ ඔක්කොටම. හරිද? So pituitary adenoma වල ACTH වැඩි වෙනවා. So these are all ACTH dependent. Iatrogenic is ACTH independent. All are Cushing's. Right? Everything is Cushing's. Right? Everything is Cushing's. මොකක්ද ඒක කියන්න ඔබ මොකක්ද අහන්නේ
to confirm the Cushing syndrome diagnosis we are doing ACTH test now.
No, after that. So to confirm it, first you have to do screening tests and then do the low dose dexamethasone. හරිද? Once you confirm it, then to find the etiology තමයි ACTH check කරන්නේ. So then you say, okay, this is ACTH dependent Cushing syndrome or ACTH independent Cushing syndrome.
හරි.
So ACTH එක diagnose කරන්න නෙවෙයි කරන්නේ ACTH check කරන්නේ cause එක හොයන්න ඊට පස්සේ. We have already diagnosed Cushing syndrome now. Right? ACTH is say, okay, is this dependent independent කියලා බලන්න තමයි ACTH check කරන්නේ. හරි?
එතකොට low dose dexamethasone suppression එක adenoma carcinoma iatrogenic ඒවා ඔක්කොගෙම
ඔව් ඒවා ඔක්කොම හරි. ඒතර ඒවා කොහොමද? ඔව්.
හරි sir, thank you.
So surgery, pituitary, adrenal, ectopic එකටත් if you can do surgery, we do surgery. Right? So surgery, whatever it is. But sometimes චට disseminate වෙලා ඔය cancers පොඩි ඒවා it's difficult to do surgery. Chemotherapy තමයි දෙන්න වෙන්නේ. Right? Right. So in paper number 2, question number 2 is based on Conn syndrome, which is again a type of adrenal adenoma that secretes aldosterone or mineralocorticoids. Right. We have talked about this, and hypertension is the classical presentation of these syndromes.
Excuse me, sir. Are you sharing?
Oh.
We are seeing the color.
පෙන්නද? පොඩ්ඩක් I share කරන්න. දැන් පේනවද?
Yeah.
හරි. Okay. ඉතල හිටලා එක මම යන්නේ. Right. Right. සමත් කාලේ තියෙන තව ප්‍රශ්න, other features of Cushing syndrome reversible with surgery. Certain ones, yes. ඔක ටිකක් අමුතු සෙල්ලමක්. ඔය acromegaly වල එහෙම ටියුමර් එක අයින් කරත් සමහරට some other features persist. Same with Cushing's. It doesn't completely go away. හරි? Yeah. Right. So, we're talking about Conn syndrome, which is an aldosterone or mineralocorticoid secreting tumor, and the classical presentation is secondary hypertension. And because there is high aldosterone, what that causes is increased potassium secretion. Potassium ගොඩාක් එළියට යනවා, right? Because exaggerated potassium secretion. And also with the potassium, you get excretion of hydrogen ion, which causes a alkalosis. So hypokalemic alkalosis is what you see. Hypokalemic alkalosis. Sorry. So hypokalemic hypokalemic alkalosis. Right. Conn syndrome does not cause peripheral edema. Right. There is a mechanism there, but now you should expect it to cause a bit of edema. Why? You can argue saying that okay, potassium එළියට යනකොට sodium okay චුට්ටකුත් වැඩි වෙනවා, but it doesn't cause edema and water retention. A level එකට එන්නේ නැහැ. Right? A level එකට එන්නේ නැහැ. Right. Okay. Now, how do we diagnose Conn syndrome, right? So Conn syndrome, again, because of the high aldosterone, you would use the aldosterone-renin ratio as a screening test. All right? That is the screening test that we commonly use. To confirm, there is something called a saline infusion test. ඒක ඔයගොල්ලෝ දැනගන්න ඕන දෙයක් නෙවෙයි. ඒ කියන්නේ එක saline load එකක් දීලා බලනවා whether we can suppress the aldosterone. Right, so you give a saline load and see if the aldosterone can be suppressed. So you challenge it, right? That's called a saline infusion test that is used for confirmation. And once you have established the excess of the hormone, then you would go and scan the patient, right? And when you scan the patients, you would see a tumor, right? And the treatment mainly is again removal of this tumor, right? That is your main treatment option, is to take the tumor out. Again, until you offer surgery, you can manage the patient medically by blocking the aldosterone receptor, because it's high aldosterone. The effects of this will be stopped when you block the aldosterone receptor, and that is with spironolactone. So spironolactone is a useful drug to manage the patient medically until you can offer surgery. Right. Okay. Right. So the last one on the adrenal gland is this pheochromocytoma. Right. So මෙන්න මේක ඔක්කොමලා දැනගන්න ඕන දෙයක්. ඔක නිතරම MCQ වලට අහනවා. This 10% rule in pheochromocytoma. Right? 10% bilateral, 10% extraadrenal, because remember pheochromocytoma can occur along the sympathetic chain, right? So it can be extraadrenal 10% of the time and 10% malignant. මේක බොරු කතාවක් 10%යි. And we talked about pheochromocytoma again when we were discussing secondary hypertension, and when we talked about this, I told you that the typical presentation of pheochromocytoma is sort of paroxysms or episodes of palpitations and sweating, headache. So these are sort of paroxysmal episodes that you get, right? Patients with pheochromocytoma get paroxysmal episodes, palpitations and sort of sweating. It's well known that these hypertensive crises can be precipitated during pregnancy. A well-known point. Right. And also there are certain other precipitants like the ones that I have listed here. Now, how do we diagnose pheochromocytoma? The simplest thing to do, right? The simplest things to do is that you can measure the breakdown products of catecholamines in the urine and the blood. So we measure the VMA in the urine and the urinary metanephrines, right? Or the urinary and plasma metanephrines. You can measure these. Once you have an established elevation of these substances, then we do a MRI or CT scan to confirm. There are also these sort of radionucleotide scans and PET scans which people sometimes used. This MIBG is an iodine tagged tracer scan which you can look for tumors, or the PET scan can also be used for certain tumors, right? So that is how you diagnose it. Measurement of urinary VMA is not now the gold standard. Now we usually use metanephrines in plasma as the gold standard. Sorry, VMA වැඩිය කරන්නේ නැහැ. The reason is it can be affected by various food substances and things. Right. And this is something you have, the last statement is something you have been taught in pharmacology, right? When you're managing pheochromocytoma induced hypertension, you have to block the alpha receptors or both the alpha beta at the same time, otherwise they get into trouble, right? So make a barrel. Hi. Pharmacology lo gontu ganla tiyena ekak. Right. So that is a MCQ about a pheochromocytoma. So Rehani, in Con syndrome, you get sodium retention, right? So the overall effect is hypernatremia. It can cause water resorption also, but the overall effect is hypernatremia because sodium. But ලොකු hypernatremia එකක් වෙන්නේ නැහැ. පොඩ්ඩක් දෙක තුනක් වැඩි වෙනවා. The upper limit of normal is what you get. Right. Hari. Okay. Right. Hari. චමත් මට දැන් මීටිමත් තියෙනවා. But we will definitely finish this hopefully tomorrow. Yeah. So the part 2 එකේ ටික අපි වෙලට ඉවර කරලා දාමු.
Okay, sir.
Hari. Any questions of what we have discussed today? So we have gone through the adrenal gland. අර Cushing's එක හොඳට තේරුණා නේද? ඒක so if there is any confusion, Cushing's වල you use the screening test, then use the confirmatory test and make a diagnosis of Cushing's syndrome. Then the ACTH is for looking for the etiology, because we described the etiologies as Cushing's as ACTH dependent, ACTH independent කියලා දෙකට බෙදුවා නේ. එතකොට ACTH dependent ඒවා වලට තමයි pituitary ectopic, අනිත් ඒවා iatrogenic or adrenal disease, adrenal adenoma, carcinoma, all those be ACTH independent. So ACTH is focusing on the cause for Cushing's. Right? And then we talked about differences between pituitary ectopic ඒ විදිහට කරා. Right. So then you want to do neurology after that, නේද? මම ඒකේ ප්‍රශ්න ටික දාන්නම් අද රැට.
ඔස්ස කට්ටිය ඒක රික්වෙස්ට් කරා.
හරි. ඒක ගාවට කරමු. Okay. ඊට part 2 එකේ ඉතුරු ටික හෙට කරමු. එතකොට ඒක ඉවරයි. කළා neurology කරමු. හරි. Okay. Right.
Okay, sir. Thank you very much, sir.
Right.
Thank you, sir.
Thank you, sir.
Okay.
Thank you, sir.